The robot really acts as our avatar. Like if you've seen Avatar, the Blue People movie. So when we're in the console, any movement I make with my hand is repeated by the robot. So we're still operating, but the robot is making those movements. So for complicated surgeries, with the laparoscopic surgery that Dr. Igwe was talking about, we think of that as straight sticks. So you have 3 degrees of movement. So you can kind of go like this, kind of go like this, kind of go like this. Like, you know, you have 3 degrees of movement, but the
it's
robot...
like if you're playing like Super Smash Brothers or something and your character has like 3 signature moves or whatever.
Exactly.
Okay, that's it.
Yeah.
Okay. Oh my God, this thing is so cool. And you just need to see it with your eyes to believe it. And in a minute, you will see it, you will believe it, you'll know what I'm talking about. The first time that I heard robotic assisted surgery, I thought, what is this, the Terminator? We can't even nail self-driving cars one step at a time, people. But this thing is cool and it's doing cool work, and cool is an understatement. It is making surgery better, safer, easier. And thanks to $5 million in donor support, we're able to do those surgeries in Durham region. That's 580 surgeries people don't have to travel to Kingston and Toronto for. They can do them in their own community. So in less than a minute, you're gonna meet the 2 women who performed the very first robotic-assisted surgery at Lakeridge Health in Durham. Dr. Elena Igwe and Dr. Julianne Francis. They are gynecological oncologists. They are smart and funny and amazing people. They're caring, and you're gonna be as awestruck as I am. It is such an honor to have them here today, talking about transforming cancer surgery right here in Durham region. So let's brace for impact with Dr. Igwe and Dr. Francis. I want the most formal introduction out of each of you. Dr. Francis, I'm going to start with you because you're closest to me.
Okay.
Yeah, just give you like the most formal, like what does your LinkedIn say?
I am the division head of gynecologic oncology at Lakeridge Health.
So does that mean you're Dr. Igwe's boss?
That is a very loose... on paper.
Okay. So that means she's got to like pick up the check whenever you go out, make sure the boss is still happy.
She does actually pick up the check.
That's nice. That's good. I need to be somebody's boss because I'm sick of picking up the check for everybody else. This sucks. Okay, so you're a physician. You've been doing this for a while. How long have you been doing this for? The whole doctoring thing.
Well, I graduated from medical school 24 years ago.
Okay.
But we have a long training process for gynae oncology. So we do 5 years of residency and then 3 years in our subspecialty. So I started working as a gynae oncologist in 2008.
What does the residency look like? Maybe Dr. Igwe, you could talk about that for a sec. Because I think like residency, I think of like university residence. You just live in a dorm and you're doing keg stands every night. Like, what is residency?
Right. No, that is like living in residency if you're a university student. No, residency is when a physician does their training to become whatever kind of specialist they are. For Dr. Francis and I to become gynecologic oncologists, we had to do a general residency in obstetrics and gynecology. So although we don't do it anymore, we've each delivered hundreds and hundreds, I don't know, maybe thousands of babies in our training because that is part of our initial training, plus a lot of general gynecology. So that's 4 or 5 years of working long hours, being on call all the time. And although it is tiring and strenuous, it's very important for us to get, as much education and learning as we can in those years. And that makes you, a stronger, more prepared doctor once you're done all that.
The hundreds of babies thing, I'm stuck on that for a sec because like I have one child. Sometimes that is one child too many. But regardless of how many children you're having, you have your obstetrician, your gynecologist, the person that's helping you. That's like kind of, shepherding you through this whole experience. And to you, that's the only baby that they're delivering, right? Okay, so you've been doing this for 24 years. You said, Dr. Francis, Dr. Igwe, what about you?
A little less than that. Julie's just a little more senior than I am. I finished my fellowship in 2018. So I guess almost 6 full years I've been a gynecologic oncologist now. And almost all of that time has been working here at Lakeridge Hospital in Oshawa.
Yeah. Mm-hmm. How do we get from that? How do we get from we're in medical school or even back up a little bit further and like, you're in 11th, 12th grade and you're talking to the guidance counselor and they're like, okay, what do you want to do with the rest of your life? Maybe your parents are like, what are you going to do? What is your purpose in life going to be? And you're like, I want to do that. How do we get from that moment to now we're sitting next to a multi-million-dollar surgical robot?
Well, I'm from an immigrant family, so there was no asking me what I would like to do.
There was telling you.
There was letting me know.
From the moment you were both told what you were going to do. Let me rephrase.
So, so I knew from very young that I kind of would like to be a physician. But at that time, I had a family doctor who was a very impressive family doctor. So in my mind, that's what a physician was. Even though there's a lot of physicians in my family, in your family, you see that as your aunt and your uncle. And so I didn't really appreciate what they would do during the day. But I did have an opportunity in high school to work at UHN for a period of time as a high school student, as a part of a co-op.
They're not letting you like open people up, are you, as a high school student?
No, but they let us
I'm sure you're very good at what you do, but at 17, you know?
No, but they let us do work in clinics, work on the floor, just see what it was like. So I had done a lot of research, actually, when I already went to university. So I was confident in a choice to be a doctor at that time. And then, you just do the usual pre-med stuff. And then
the usual
medical
stuff.
school.
The usual 57 years of school, and you're done. You're good at that point.
The usual marathon, yeah.
How do we get from that point?
Yeah. I mean, I would say like my journey to becoming a gynecologic oncologist, it wasn't straight, from when I was 5 years old. I knew this is what I wanted to do. I knew I wanted to do healthcare and medicine. And yes, eventually I got into medical school. But I'll say it was during my general residency, OBGYN, where I got to work in the oncology division, where I got to see what this was all about, really helping women and making a difference and giving people more time to be around with their family and friends. And the complexity of what we deal with, was all very interesting and intriguing to me. And that's how I got to become, this kind of surgeon. And then, as technologies advance, we get crazier and crazier things like our awesome, Optimus Vinci Robot here.
Is that the name you have for it?
I
the
believe the
name?
name
That
is
was the name.
Optimus. That was chosen. I think it was a survey and like the foundation members got to vote and stuff.
Yeah.
I'm surprised there were no like robot McRoboti face. That like Bodie McBo face that pops up. Yeah.
Right. I don't think there were any of those.
I personally wanted to call the robot Mona.
You were about to say her.
I was going to say her. I was going to say her.
The robot is a woman to you, okay?
Which means a girl. So I wanted to give her a female name.
Yeah.
But,
Why Mona?
Mona Lisa.
Mona Lisa, okay. Yeah. And
Da
probably
Vinci.
just as expensive, honestly. Right?
Oh, yeah.
Mona Lisa's worth like $1 billion. It's pretty close.
Yeah.
I want to talk in a moment about how this makes your job not necessarily easier, but makes you each of you more effective healthcare providers. But I want to first talk about the oncology part of what you do, the oncological part of what you do. I'm a cancer survivor myself. It's been a couple of years of remission for me. I have to imagine being a doctor of any kind to be very heavy to begin with, but adding, it's scary. You're dealing with patients that are literally fearing for their lives and some patients that, you might not be dealing with for very long, unfortunately, depending on what the staging is of their malignancy. How do you take care of yourself mentally with that portion of it? How do you make sure that you're, being the best you possibly can for your patients? You got to put your own oxygen mask on first.
Well, I think we're really lucky because we have a very strong team. So I think my colleagues are incredibly supportive. Like, I think we make a certain amount of effort. Like, if a case is really hard that day or a situation is really hard, we talk to each other about it. And every case that we do gets reviewed in a multidisciplinary team. So the surgeons are there, but the radiation oncologists are there, the medical oncologists are there, the pathologists are there, the radiologists are there. So we really have a huge team that helps us make the decisions on every patient. So when I decide to do something, I have the confidence that not just my own mind and training and everything is deciding what happens for this patient. I have a whole team behind me. And also, when we're working, there's never any hesitation to call for help, to have a colleague, even from a different service, come in and help you. And we're so lucky at Lakeridge to have really collegial teams on every service. So it makes you feel that you're not alone in this. And so I think that for me, that makes a big difference.
No, I completely agree with that. I would say, Julie as being my partner for the longest time, and our other partner, Paulina. I mean, we have a group chat that like we are constantly texting.
Yeah, what's
each
going on
other
in the group chat?
Oh, you don't want to know. You don't want to know.
Some pretty white hot memes. Yeah, let's make sure that management doesn't find out about it.
But one thing we often do is message each other after our cases, and particularly if it's a challenging case, to be like, whoa guys, we just had to do this or whatever, or if not everything always goes perfectly, if something goes wrong, we share our problems, complications, and we all help each other kind of go through that. I would say also, I talk to my partner at home, and although he's an engineer and has no idea what the heck I do. Or
I was a bit of a tone when you said engineer.
Well, engineers are. No, I'm kidding.
I'm also married to an engineer.
Her husband's an engineer too. Yeah.
What about you said your other partner is Paulina? Pauline?
Yeah, Paulina, yeah.
Is she also married to an engineer?
No, she's lucky her. No, I'm kidding. But I think even people who aren't exactly going through the same thing as you, like our family members, they do help us cope with our challenging cases and stuff, and help us put things into perspective about, we're helping people, to the best of our ability. And sometimes things are just hard.
So on a day-to-day basis, and I don't want to speak for every moron, but I'll speak for the moron that I am. When I think of a gynecologist, I think of, you're helping women with reproductive health, reproductive regions, let's say. You're a gyne oncologist, so are you just dealing, when I say just, are you dealing with cancers and issues that are strictly related to that? Are there other parts of the, like, what is that? What are you dealing with every day?
So it is like basically what you're imagining. So we take care of cancers that occur in the ovaries, the fallopian tubes, the uterus, the cervix, the vagina, and the vulva. But those cancers can travel to other places. So we're pretty comfortable anywhere in the abdomen, I would say.
Mm-hmm.
And is that also where like the, one of my oncologists called it the tumor board?
Mm-hmm. Yeah.
They were like, that's the kind of the group I think you were referring to afterwards, the multidisciplinary team.
Yeah.
So I would imagine if a cancer, let's say, starts in the reproductive, the fallopian tubes, for instance, and then travels somewhere else, are you like still working with that patient, or because it's traveled, like, are you teaming up? What does that look like?
So we're still working with that patient, but sometimes depending on where it is, we might work with some other teams depending on what we have to do.
Yeah, I mean, sometimes our cancers, because they've spread, we still are doing a surgery to remove the cancer, but maybe we also have to remove a non-gynecologic structure, like the spleen or part of the liver or part of the bowel. And that's sometimes we manage that alone. Sometimes we get other surgeons to assist. So even if it's in a different, organ, we can still remove all of the disease is usually what we try to do.
Now, you've both been doing this for different spans of time, and so I'm curious, some patterns that you've seen over time, like how has patient care changed in the 24 years you've been doing this, the 6 years that you've been doing this? What are maybe some of the issues that people are encountering more compared to earlier, less compared to earlier, because treatment, hopefully gets better every single year?
So the patients are living longer, so that's a great thing, but
Thumbs
that's
up for that.
because the care has become a lot more complex. So one of the things I would say is that the types of treatments or the number of kinds of systemic therapies that we can offer have really changed. And
can you give me an example?
Well, like 5 years ago, we didn't have immunotherapy in a meaningful way. Like we were aware of it.
That's that's the only thing that killed my cancer. Yeah.
Yeah. So we were aware of it, like it was a known thing, but we didn't have it generally available to give to our patients. PARP inhibitors came in maybe 8 to 10 years ago. So that's another whole class of systemic. So I would say in the past 10 years, maybe there's 4 or 5 new classes of drugs, not 4 or 5 new drugs, 4 or 5 new classes of drugs. There may be many drugs within that class.
Would that be like hundreds, thousands of new drugs?
I would say a couple dozen, maybe.
Oh, a couple dozen, okay.
Yeah. Not all of them have been equally as effective, I would say, but we have at least a half a dozen that we did not have as recently as 5 years ago that are pretty effective. So that's a huge change.
Okay. Just like differences compared to like today, for instance, versus 6 years ago, or even like when you were in medical school, for instance.
Yeah, that's a good question. I mean, I think one thing that we still see a lot are patients who are overweight and obese. And I do think kind of probably nationally and internationally that has likely increased over the years. I mean, Ozempic is a new thing that has helped a lot of people.
Vitamin O, yeah.
Right. But a lot of our patients are morbidly obese. A couple of particular types of cancers that we treat are caused by obesity, actually.
Can you give me an example?
Yes. So some of our uterine cancers are what we call more low-grade uterine cancers are caused by excess estrogen production. And actually your fat tissue produces excess estrogen. So people who are very overweight more commonly get these cancers. So we see a lot of these patients. And, you know, we'll probably talk about this more, but those are a lot of the patients that we opt to do our robotic surgery on, because it's challenging to operate on a very large patient to focus deep in the pelvis. And the robotic device absolutely helps us do that.
You're in here and you're like, I have cancer. And also like, I'm super self-conscious now.
Yeah.
I actually don't really find that a difficult conversation to have, because I just speak about it openly the way I would speak about anything.
Yeah.
And I find that most patients, because I'm respectful, because it's difficult. And we know a lot more about obesity now that we didn't know before. So I'm not judgmental, because what we know about metabolic syndrome today, we didn't know like 10 or 15 years ago.
What's metabolic syndrome?
So it's basically a situation where if you get to a certain level of weight, it doesn't matter how well you try to follow the ideals of eat less and move more. Your body is fighting you to maintain the weight that it has achieved.
Really?
Yeah. So like, unless that person is living in a calorie deficit continuously and never making a mistake, because as soon as they do, their body will try to put those calories back.
That's super frustrating.
It is almost impossible to overcome. Only 3 to 5% of the population can lose weight from those higher obesity classes and keep it off. So now there's a lot of research going into that small percentage, but the vast majority of people don't fall into that category. So like when I express these sorts of concepts to patients, they understand that I'm not judging them about what the situation is. We're just dealing with what the situation is. And in life, you have to deal with the situation that you're presented with. So there are some additional challenges to taking care of patients who are a bit larger, and the robot really helps us to do that.
What's something about your day-to-day that the average person might be surprised to know that like you do? Like that's part of your, I didn't know that they did that. You're laughing. What is it?
I'm just thinking, because when I was a kid, I went to the grocery store with my mother once, and we ran into the family doctor there, and I was just like, you buy potatoes? Really?
Yeah.
Like,
It's like seeing your school teacher.
What
or
are you
whatever.
doing here? Yeah, I go to Costco. I
Okay,
really do.
Costco.
And I'm always
Executive
running
membership?
Executive membership, and I'm
Otherwise,
always running
what's
into
the point?
patient there, right? Exactly.
So shopping for food is something that people wouldn't. Okay, got it.
I wouldn't
All right.
expect that. Oh, geez. I don't know.
Like maybe a particular
More work
health
related?
thing that you might deal with, or a particular like maybe there's a particular procedure that you do.
Now I wouldn't say anything overly interesting. I'll say previously, when I was in my residency days, I used to do a lot of circumcisions and on newborns, and not every residency does that for like the OB residents. So when I tell people, or if it comes up, because it's not like I'm openly telling people this
At
but,
Costco when you're buying
At
potatoes.
Costco when you're
Anybody here need a circumcision real quick?
Yeah, exactly. Yeah, I have done hundreds of circumcisions, which is a little unusual,
Yeah.
I guess.
How long does a circumcision take?
Oh, 5 seconds.
Yeah?
It's very
Damn,
quick.
okay. I think this is a good segue to get into what the robot can do. How does this decrease surgery time? How does this improve patient survival, patient success?
Yeah. So particularly, I'll speak about like I think there's a couple of classes in which the robot's really good for us. It's our obese patients and then just our complex surgical issue patients. So speaking about the obese patients, I mean, honestly, just like physically for me or another surgeon to be able to, reach around certain patients while we're doing our conventional laparoscopy, which is with us standing beside the patient.
And what's that procedure?
So that's like myself and an assisting surgeon standing beside the patient and using manipulating sticks to do the surgery, but I'm using my hands to manipulate the sticks right next to the patient.
And you're talking about when you're like, this is pre-robot, you're just using like
yes, it's called
elbow grease.
Conventional laparoscopy. Yeah, it's quite taxing on us, and because of that, it can make us not be able to do everything we want to do or completely access things the way we want to access them, and remove enough lymph nodes and whatnot when we're trying to assess the cancer. So the robot totally replaces that problem, absolutely, because we are at the bedside console manipulating these arms that we place along the patient's abdomen, and the robot has to do all the reaching, not us. And so it gives us far better ability to access the deeper areas of the pelvis that sometimes we just can't reach to in normal laparoscopic surgery. So for our obese patients, it really helps us keep the surgery as laparoscopic, like small hole surgery, because sometimes if we were struggling, we may want to just stop that laparoscopy and make a cut in the abdomen, right? Which is longer recovery, more risk of infection, more risk of abnormal healing. So this allows us to keep it all small hole and have the patient have a quicker recovery, get the tissue we want out, less hospitalization stay, less blood loss. So in that population, it's perfect. In the complex surgical population, maybe Julie wants to talk about that.
Well, the robot really acts as our avatar. Like if you've seen Avatar, the blue people movie. So when we're in the console, any movement I make with my hand is repeated by the robot. So we're still operating, but the robot is making those movements. So for complicated surgeries, with the laparoscopic surgery that Dr. Igwe was talking about, we think of that as straight sticks. So you have 3 degrees of movement. So you can kind of go like this, kind of go like this, kind of go like this. You have 3 degrees of movement, but the
it's
robot...
like if you're playing like Super Smash Brothers or something and your character has like 3 signature moves or whatever.
Exactly.
Okay, that's it.
Yeah,
okay.
and,
exactly.
But the robot has 7 degrees of movement that are the same 7 degrees of movement that your wrist has. So any movement I can make with my wrist, I can make it with the robot. So I have many more arcs and curves and turns that I can make. It's just a lot more facile. So when we're trying to do something that would be really complicated, the robot makes it a lot easier to do it.
Can you give me an example of something?
So like, for example, if the bowel is attached to the tumor that we're trying to do, it's possible with the robot for me to very finely tease it off with just tiny little microscopic movements that would replicate what I would be doing with my fingers or with a tiny instrument open. You can technically do that laparoscopically. It's just a lot more difficult, and it depends on where it is. Also, the robot lets us look down angles and up angles. So
what are you seeing the whole time? Is it a video camera? Is it like a heat map?
It's a 3D image or a 3D view of the inside of the abdomen.
And is that happening in real time, or do they have to scan the patient beforehand?
No, in real time.
Okay.
Yeah, in real time we're looking at that. Yeah.
So this is what you're seeing, and then you're able to zoom in.
You can zoom in, you can zoom out, you can look up.
Take us
you can
in
look
there
down.
with you. You sit down. What happens?
You have basically any arc or any degree of movement that you want to have. So I can look around any corner. So laparoscopically, I was limited by the camera. I was looking this way, but with the robot, I can put it there and turn the camera around and look up.
So there are cameras in the instruments.
There is a single camera.
Single camera, okay.
And that camera can look more or less in any direction that's below where we've put the camera.
That's nuts.
Technically, if we turn it around, it can also look up. So we have the whole view
and then
of
you'd
the
see
entire...
yourself maybe, right? You just want to wave to yourself. You're like, hi,
Hey,
what's
how's it
up?
going? Yeah.
You must think sometimes that you're just like, this is kind of nuts, right?
It's
You're like,
cool.
what am I
It's
doing?
pretty cool.
It's cool. Yeah.
It's pretty cool. It's a big change in technology. As Dr. Igwe has pointed out, I'm much older, right? So I've seen every generation of surgery. I feel like I'm a surgeon of my age is crossing a lot of boundaries that probably won't be seen again because when I started, we were doing lots of vaginal surgeries. Unless you're a specific subtype of gynecology, we don't really do that anymore because it's not necessary because we have laparoscopy.
Can you give me an example of that, please?
So like there's a lot of prolapse repair surgeries and stuff we do, but we used to do hysterectomies vaginally. Like we would just take them out that way. That would be a very unusual thing to do now unless you're a subspecialty called a urogynecologist who's basically helping women with pelvic problems.
Yeah.
We did a lot of open surgery. We did a lot of laparoscopic surgery, and now we're doing robotic surgery. So it's really been interesting to see the whole arc of medicine and the different types of surgeries that we can do. Like I went from, we deliver babies, breech. We never deliver babies, breech. The breeches are back. So I've seen a few pendulums.
It's kind of like egg yolks, good or bad, right?
Yeah, exactly. Like, do you
this
eat
year
them?
they're good
Do you
for
not?
you? I don't know.
Yeah. So there's a lot of things that have come and gone. And so it's been interesting to watch medicine change.
Yeah.
It's pretty incredible, actually.
What I'm hearing a lot of is this is better for patients. Yes, the robot is expensive, but you gotta spend money to make money. And it's also saving the hospital a ton of money because people aren't there. Their recovery times are shorter, right? Because there's less to recover.
Yeah.
You're getting the same surgery. You're getting a better surgery.
Yeah.
So it's less strain on. There are fewer people. When I say taking up hospital beds, you know what I mean. Occupying them, so we can get more people through here. For less money over time. It sounds like.
No, that's correct. Yeah. Over time, it certainly, becomes economical. Initially, yes, it's a large amount of money that the foundation, helps put out and all the donors. But for sure, it is beneficial in every way.
Do you have a lot of patients like requesting this? They're like, hey, and I've been there myself. You're like, this is happening and it sucks. Like 0 out of 10 would not recommend getting cancer. But do you have patients going like, but I want the robot? Or do you have some patients, because, like I wouldn't necessarily get in a self-driving car. Yeah. And I know that this isn't self-driving, but I'm, again, a moron. Do you have some patients going, I do not want the robot?
I've had a few patients say, do you mind if you stop by the surgery while the robot is working?
Oh, they want to see.
They think that I'm not operating.
Yeah, not thinking that Dr. Francis was in the operating room.
Oh, they're just like,
robot
it's on
the robot is
autopilot.
operating. So I have to explain, no, I'm still there.
And you're in the same room.
I'm in the same room.
Yes.
If they were conscious, you'd be able to chat, right?
Yeah, exactly. Yeah.
Do you ever have patients that are like, again, come in and they're like, that seems like the great standard of care now. I want the robot.
I wouldn't say they ask for the robot, but if I tell them that they're on the robot, most people are pretty excited about that.
Yeah. I'll tell you, so I was I did the first case here at Lakeridge, and the very first patient, she certainly was a little bit nervous, but, of course I made her comfortable. It wasn't my first time doing robotic surgery, right? I had training in robotic surgery.
I mean, we would hope, right? We're like, get in there, kid.
Yeah, exactly. So I have had years of training. And it was just exciting for us to get the robot here. But yeah, she was a little bit nervous to be the first case of all robotic cases here at Lakeridge. But I still see her now, every few months. She's doing great. She's healed well. And, it certainly helped her. But yeah, otherwise, I don't have patients saying that they don't want it or anything.
How did that feel, though, to do the first one in this hospital?
I know.
It had to be a little bit, yes, you've done this before, obviously, but that has to feel like you must have butterflies, right?
Yeah, I'm not going to lie. It was a little nerve-wracking. I mean, I certainly felt prepared, so no concerns in that regard. But for sure, because I knew everybody else knew and was waiting to know, how did it go? Kind of thing. Yeah. But actually that day had lots of lovely support. Dr. Francis was there. Yeah. Our other partner, Dr. Sabalska, was there.
Yeah, the group chat popping off.
Yeah.
Just to help support. So
they're FaceTime us when you're in the middle of it. We want to see.
Yeah, exactly.
So I remember seeing this thing in person. I think it was September or October. What is time? 2023. Yeah. And I was hosting the fundraising gala, and I think $20 or $21 million had come in. And I remember seeing this thing and seeing the module, which are right behind you over there. And they had someone there, and they had people come up. You could watch it. Watch a demo. It was really cool. And I remember talking to the organizers, and there was a lot of uncertainty about whether or not it was going to happen. And then this, donation finally came through, this $1 million donation. What were the conversations like officially, but also amongst yourselves as the potential beneficiaries of these things? Or of this thing, rather, singular.
Well, I was excited because I had been working to get a robot for a long time. So my original training was at London Health Sciences. And at the time that I trained in London, London had 3 robots when there were 3 robots in Canada.
How did they get all of them? That's not fair.
Not for me to say.
All of them?
They had all of them, yeah.
Out of control.
So so I had trained on the original robot. Like it's like being on the original iPhone. Like, It doesn't even have a number. Okay.
It just has that beer app. Where you tilt the beer and it goes in your mouth.
Exactly. So I had wanted to get another one, and I went to work at Queen's, and I worked for 10 years to get a robot at Queen's, and the week after I left for Lakeridge, Queen's got its first robot.
So this was vindication in a sense,
so
right? You finally got one.
I got here, and I was like, one of the first things I did was speak to Dr. Dickey, who's the head of all of surgery here, and said, how do you feel about us getting a robot? And he's like, I think it's a great idea. Let's work on that. And then we had the pandemic, So for a little while, we had to readjust our priorities, but we brought it back. And one day he walked up to me and said, the pandemic's going to be with us, COVID's going to be with us, so we might as well move forward with our goals. And we got back to work, and it was really amazing how well everybody put everything together after that. Felt like every piece just fell into place. So I was unbelievably excited when we got the funding, and I was unbelievably excited when I heard we were going to get the robot, because I felt like it was like a 15-year
quest.
Quest
finally
to get a robot.
Got to the top of the mountain.
Finally got there, so it's a pretty good feeling to have the robot.
But like the delivery, was it like, pardon the pun, was it like an email? Was it like did they have a pizza party for you? Like, how do you find out?
Yves Gadler called me. He called
CEO
me.
of Lakeridge Health Foundation,
And he said, we did. I was basically shrieking on the phone. So, I was very excited. I'm not going to lie.
Yeah. And we had a clap in for the robot, right? I think all of the...
I'm sorry, what's a clap in?
Yeah, I know.
So there's a tradition at Lakeridge, which I think is one of the best Lakeridge traditions, which is if you've worked for Lakeridge for many years, when you leave on your last day.
What is many years?
Well, I don't think I've ever seen them do it for somebody who'd been here for 2 years. But if you've worked here your career and you retire, so you've made an investment in the organization, on your final day when you leave the building, everybody that works in your area comes to clap for you as you exit the building on your final day.
Yeah.
So we made kind of a joke in a meeting saying that, maybe we should clap the robot in. And I was like, no, we should clap the robot in. Like, we worked so hard to get this. So it was pretty exciting to see it come. And it was great because the Verweys were there. So they were able to see, like the hard work that their donation made, and other donors too, to contribute to us getting the robot. It's pretty wonderful.
Do you both remember their reactions? And also what it felt like $1 million is a lot of money.
Yeah.
And to get that, and to know that family is the reason why we're sitting next to this giant, very intimidating, very scary, kill you looking machine. What was the look on their faces? Or the looks on their faces?
It was great. I think a great experience for everyone. I think they were so happy to be able to help their community in such a significant way. Yeah. And we were so happy to accept this gift.
You shouldn't have. No, don't take it away. It's ours. You can't take it back.
Right. To help us help everyone else in our community. I think that it was remarkable. And, we've had a couple of showcases, I think, before we started on the robot with all of the donors who would come, and
each of them got a free surgery.
Well,
like, what do you want?
Not exactly.
BBLs for everybody.
Not exactly, but they got to get up close and personal, and some of us did a few demos on it, so they could really kind of see what they help us provide.
Yeah.
Mm-hmm.
Yeah, so cool.
But it's a really interesting device. Even every piece of it has so much technology in it. Even the little scanner at the back, where it shows you the person. I think they had the same person who designed Iron Man designed that.
Oh, interesting. I didn't know
They're
that.
like, Marvel, my side gig, my side hustle is also making medical equipment.
Yeah.
And actually, I know the movement, because the robotic tool moves. It's like Segway movement. Like those Segway devices. Like that's the technology. That's
so
the
Interesting.
It just slides.
So, anyways,
so
it's very
beautifully.
so much technology in there.
Yeah.
It's remarkable.
What about, because like anytime you drive a new vehicle, for instance, or like you try a new thing, there's a learning curve, right? Like, because it's very tactile. It's very, what's the adjustment period like for that? Or can you set like different profiles? So like my hands, this is my profile, this is your profile, like in a vehicle with the seating position?
Yeah, so we have profiles on the robot. I felt like for me, what was funny was like the docking is really different on this robot than the one I was originally trained on.
What do you mean the docking?
How you attach the robot to the patient and even a little bit the instrumentation.
You need a new word. Docking is scary.
Docking is scary.
We're docking
like
the patient?
docking a boat.
Yeah, like pirates.
But once I was like looking inside the patient and moving my hands around, it felt incredibly natural because that's where I live. It's where I've lived for a long time. So once I was in, I'm like, oh, I'm in.
Yeah.
Like, this is totally
Again, very
where I
creepy
feel.
language. Once I'm in my patient, I'm like, we're getting canceled for this one. How do they, do you have to do some sort of, and I'll bring it back to something very simple, but something that we all have experience with. When you get a new iPhone or you fire up your new MacBook and you need to say to, and I'm not going to say the word because I'm sure there's a bunch of iPhones in here and they're all going to start talking at the same time, where you have to like say a bunch of different phrases and then it can understand what your voice sounds like so it's not detecting other people. Is it the same thing with like hand movements?
No, it's translating your exact movements, but you do have the option of customizing a delay.
Okay, so maybe that's what I'm referring to.
So you do have that. But also like we do have our own profiles of like how tight we want it to be and where we're sitting and what kind of angle we want the camera to be at and things like that. But I would say like we had quite a lot of time because they gave us one of these like monitor, like the console over there. We had one for a few months before we went live with the program. So all of the surgeons involved had many hours on the simulator before we did the first cases. And it actually kept your profile from that. So when you go to do the first case that you're doing, the computer's already set up for you. So
Interesting.
Because we each have our own profiles, like when I go to the console and I press, Dr. Elena Igwe.
Do you have a code?
Pardon?
Do you have a code you have to type in?
No,
you
not
should
not
get
a code.
codes. That's a lot cooler.
If it was Julie on it before me and I press Dr. Igwe, everything moves up like a foot and a half to get to.
So there's no confusing it.
Yeah, exactly.
There's no confusing it.
Yeah.
The success of the program, like in terms of I think one of the greatest things about the launch here is that so many services launched simultaneously. And like I'm kind of the keeper of all of the data. So the learning curve on every team has been incredible. The conversion rate, like, okay, we couldn't finish it on the robot we had to open, has been incredible in terms of it's very, very rare that somebody had to open. And the complication rates have been very, very small.
You're like a wizard.
So like the whole team, like not just our group in gynecology, but the urology, general surgery, thoracics, like the numbers that have come out of the team, I could not like be more proud of how this organization has performed. Like
amazing.
Great work from everybody. So
you're like, take that, London, with your 3 machines when nobody else had any.
Yeah.
Now this is number, I think, those are the original 3. I think this is number 32. But across the country, which would be a little bit less than 1 per million. In your opinions, like, I shouldn't say obviously more is better, but because there's a point at which you just don't have the space for them or whatever. How many more of these could you use?
That is a really tough question you're asking.
Well, you're very smart people,
Totally the
so.
wrong person.
Julie will probably say 7 more. or
Probably.
so.
I mean, for me, like if I only operated on the robot, other than things that, like in terms of going into the abdomen, I would be very happy.
With Stefan?
Like I would like my own personal robot.
Your own.
All right.
And then you could call it Mona.
Of course you
You know,
Yeah.
that I could call it Mona. But
You put some decals
it's hard
on
to
it.
know like how many we need for the whole system, because there's certain things where laparoscopy is still always going to make sense because it's quick, it's fast, it's not using a tremendous resource to get it done. Right now, like any technology has a maturity point, right? And the robot hasn't reached that. So like right now, nobody would suggest that you mow your entire lawn with a push mower. Unless you had a very postage
if you want to save on a
lab,
gym
you
membership,
know?
right?
Yeah, right. You know, but most of us
Close
have
those
a
Apple
machine,
Watch rings, you know?
you know, so and there was a time when laparoscopy was robotics. I'm old enough to remember it, right? Like how long it would take to set up a laparoscopic case, what percentage of the surgeons were familiar with it and comfortable to use that technology. Laparoscopy was robotics, like 15 years ago, 20 years ago. So like 15 or 20 years from now, I would expect that Dr. Igwe will be able to speak to her junior colleague about the good old days when she used to just pull out a straight stick scope and do that surgery. And they'll be like, okay, Unc, you know,
You're like, now it makes chili.
you know,
It's making me lunch when I'm operating.
you know, like, you know,
Right.
now they're like running the app while they're doing the surgery. Don't know what she's talking about. So
Doing dances on TikTok or whatever TikTok
exactly,
is in 20 years.
you
Yeah.
know? So technology changes. But I expect this one will mature. Like eventually the robot will just be part of what we do.
What would both of you like to see in the next version, like in the Mark II or the, you know,
Well, that's a good
15 Pro or
question.
whatever?
I already know.
Okay.
Because I've been to see it.
Oh.
And I've used it.
Well, no, but
And
like what would you want?
And
Who- you
let me
know.
tell you, it has what I want. Because the biggest issue with robotics right now on the machine, it's not a game-ending limitation, but we don't have what is called haptic feedback. And haptic feedback
Yes.
is when you can touch something and
And
feel
it
it.
vibrates or something, yeah.
You can feel it. And the DV5, which is the newest Da Vinci robot,
And this is the 4?
this is the XI,
XI, yeah.
does have that. So the next generation does have that. And so it has a bunch of other little features, which are like kind of like your iPhone upgrades, where you're
Yeah.
like, yeah, okay, whatever. But
Cinematic mode.
you know,
Nice.
but being able to feel what you're touching, you can feel if it's soft, if it's hard, you can feel how much you're stretching something if you're stretching it. That's huge.
Because right now there's no differentiation.
No,
if it-
now we're looking at it, and so we're looking at what we think how much tension you're putting on the tissue. So, and like I think our complication rates are very low, so we're obviously good at that. But to be able to actually feel it, like that's huge. So
It's kind of like training for a marathon with ankle weights, and then marathon
Yeah,
day you take them
yeah.
off, and you're like, oh my god, I'm even better at this than I thought I was. This is awesome.
Yeah.
What would
Yeah.
you? Well, actually, Dr. Igwe, what would you like to see in the next one?
Yeah, I mean, that is probably the most important thing. I think what Dr. Francis mentioned. Yeah, and and just here at our hospital, we have one robot, which is excellent. It's particularly excellent for like the amount of surgeons who currently use it. But as more and more people are trained on the robot, it would be great to have more access to it, and maybe that means another one or so. So I do think more, not more and more and more is better, but a little bit more in regards to the robot is better, just because there's only so much that we can share, right? We all want our patients to have access to this, the ones who need it. And, we do have more surgeons who are being trained and hired who do use robotics. So, it probably would help our hospital eventually if we had another one. But certainly this is an excellent start.
Yeah.
What would you each say the split is between robotic and non-robotic surgeries? Like on average in a month, let's say.
So for our team, I
Yeah.
can't speak to every team. It's about a quarter
A quarter with the robot.
with the robot.
Okay.
Yeah. And honestly, it could be more if we had more time with it. Unfortunately, we only have so much time because
Yeah.
we have to share.
Who are you sharing it with?
The general surgeons, the urologists, and our thoracic surgeons right now.
And general gynecology will start
Yeah.
in the fall.
So do you have to like sign it out? Like who gets no, but like who gets preference?
We get a day
like,
a week. We get a day a week.
A day. What day of the week is it?
Yeah.
We get Tuesday.
Okay.
It's a good day.
We're recording this on a Friday, so does nobody have it on Fridays? I guess I get it on Fridays.
On
You both have worked in different regions, right? We talked about London earlier, the University Health Network.
Yeah.
Durham region is particularly special, not just because I was born and raised here and live here now with my family, and not just because you're both here. I think that the three of us we're the difference in Durham, I think. I'm going to include myself with a couple of life-saving heroes over here. We do equal work. But what does it mean? Because the work, does it feel more personal when you're dealing with a smaller community like this? And when I say smaller, Durham region is still the fastest growing region in Canada. It's got hundreds of thousands of people. But what's that difference? Like, what's that feeling?
Yeah. Yeah, I think it absolutely makes a difference. I'll tell you, my boyfriend is from a very small town in Durham region, and, I mentioned his family's name, and everybody knows their family. It is just a greater sense of community here, and feeling that you're directly helping someone who is close. And, it's good to not have to have the patient to travel far for their care, easier access for them to see us and follow up with us. For me, I live in Oshawa now. I moved recently to be closer to work. It's just a lot easier. I grew up in Hamilton, which I find is very similar to Oshawa. So for
it's
me,
like the Oshawa of the West.
I really
right?
think it is.
Yeah.
I think they are so similar. And so for me, it really just feels like home, and it feels like I'm helping my neighbor, and that's what I love about it.
Dr. Francis?
I would say for me, like, I've always been interested in meeting patients where they are. So
What does that look like for you?
So I had worked at Queen's for 10 years. And during that time, we used to travel to Oshawa to provide care for patients here. We would see the patients here, and then I would bring them back, do the surgery in Kingston, and then the rest of their care would be followed up in Durham region. But eventually, Durham region was growing to be so big, there wasn't capacity to do all those surgeries in Kingston. So that's how we came to open the program in the first place. Mm-hmm. But I think also, like, I've worked in Moose factory to, like, provide some care up there so that those patients wouldn't have to travel. I do some work in developing countries. So I think I've always wanted to be more where the patient are, because it's so hard for people to travel and not be with their families, or for their families to not be with them when they're going through some of the most difficult parts of their lives. So I would say working here is just an extension of me feeling that way.
And where does that come from for each of you? Because I think a lot of people, we're busy living our lives, right? And a lot of people, I would assume it's different for people working in healthcare, but some people might treat it as a job. Yeah. And I'm good at my job, let's say, and whatever. But like, I want to get home. I want to get back to my family. Like, I don't really care where I do this. I have a skill. It's in demand. It is what it is. But like, where does that come from? Like, you talk about working in developing countries. You talk about, like, I'm in a new city, but it still feels like home. Like, maybe Dr. Francis, you could start. Where does that come from? Where does that live inside of you?
Well, for Durham region, like, I didn't grow up in Durham region, but I grew up, like, off of Port Union Road. So it's, like, right next door. So it's part of Central East. So for me, this is home. Like, I feel really comfortable, and the community, you just know people in the community. These are your people. So it's hard not to feel completely connected to it.
But even, I mean, on a deeper level, like, maybe your upbringing, or like there were people you admired growing up, or like, where does that live in each of you?
My family, like, as I was saying, I had a medical family, so and I have a very religious family, so there's a lot of missionary work. So I would say that's part of my upbringing.
Makes sense with the traveling.
Yeah.
Right? Missionary work. Yeah.
So it might be partly that, but also I feel like the cancer clinic here was started by Peter Dixon and Dr. Peter Dixon, and that has always been his philosophy for this cancer center. So I think there's a certain degree of mentorship and seeing what is of value and understanding that and having that kind of leadership.
Yeah.
So
I'm hoping you can talk about being not just women in healthcare and women doctors, but also Black women and women of color. My wife is a Black woman, and it was really difficult for her and many Black women to find doctors who look like them and who take them seriously, right? I mean, I'm preaching to the choir. We look at mortality rates are higher for Black women who are giving birth, and you're seeing that literally day by day.
Yeah.
How important is that for you? What are those conversations like? What are patients' reactions when, because it's so difficult to get a doctor at all, when it's a Black woman looking for a doctor who can understand who she is and meet her where she is. What is that like for you?
So like for all of my patients, I would say like I do my best for all of my patients. I think that like, you know, when I see a patient, I think that could be my sister, that could be my mother, that could be my friend, that could be my daughter. I'm old enough now. So I do think about that when I'm taking care of them. And a lot of my choices are influenced by thinking in that way. But I would say when I have patients of color, being aware of the literature of in terms of women of color trying to seek healthcare, I consider that. So I would say that I do try to give them that little bit of attention where I'm really listening. I want them to know that I'm really listening because I have some sense that for that patient, this may be the first doctor that has ever really listened. So I do consider it.
I think, you know, the medical field certainly is becoming a lot more diverse in every aspect, you know, sex, race, you know, religion, all that kind of stuff. So it's not as unusual, I think, to see a more kind of multicultural doctor or team, you know, nowadays. So I haven't experienced, I feel like, too much, I don't know, surprise or anything in my patients. You know, maybe Julie sees a big difference over time, but I haven't so much. I think, you know, my patients are usually like, "Oh, are you old enough to operate on me?" kind of thing. You know, which I take
no,
as
I'm
a
actually
compliment.
not. So I'm going to get out of here. Best of luck to you. Thank you very much.
Exactly, but you know, I feel that. You know, I don't think that we experience much discrimination or anything just being women in medicine.
You're dealing with equipment that people around the province and people around the world are salivating over, right? I mean, you've both salivated over this and now you have it and you can see it from both sides, right? Especially when it just like evades your grasp. This takes money and it's not all funded by the government, of course. And we've talked about, not just in this episode, but in every episode of this project, we've talked about the power of community and how it is incumbent upon all of us to really come together. We talked about like, you know, seeing your neighbors as people and you're bumping into them at Costco and whatever. But what's that message to people that maybe have been thinking about donating or maybe have donated in the past and haven't done it in a while? How do you communicate that on a person by person basis and say like, you want one of these? Pull out your checkbook. Maybe a little nicer than that. But.
Well, what I would say is that, like, in Canada, we're in a situation where I believe, I could be mistaken about this, every robot in the country has been purchased by donor dollars. And so the power of a community to come together and do something like purchase a robot or another significant type of surgical equipment really can change the outcome of people in that community. So I think giving where you live is so important because those dollars are going to help you or your family member or your neighbor. It's really locally sourced and locally grown, so to speak. So giving dollars close to home are so important. I can't emphasize that enough. And, you know, we think really carefully about what is going to happen with every donor dollar that comes in my sphere. So sometimes they'll say, okay, we have this much. What is the most important priority that you have right now? And I'll talk to my colleagues and we'll come up with something that we think is the most important thing that we need right now that we wouldn't be able to get without those donor dollars. So
like a jury almost.
Yeah.
Like we need a consensus.
Yeah, we really need this one. So I would say that like those dollars make a huge impact, right? Because we don't always know in terms of capital budgets when we will next get something. So when we get those donations, it's huge. It's huge. It makes a big difference.
I think it gives us a great sense of pride that people in the community care enough to put their hard-earned money to help other people in the community, because that's what these donations do. Yeah. And, you know, all of us, all of the surgical teams, staff, everyone who benefits from these donations, we are overly grateful that this has been done and that, you know, people care enough to help us help others.
Yeah. I mentioned the gala earlier, the Lakeridge Health Foundation gala that I hosted last year, and to see like $21 million raised.
Yeah.
And like,
Yeah.
you know, I'm not going to do the math on this, slightly over 5% of it, I guess, went towards this particular thing. Like that's going to make you feel really cool, right? That those people that you're driving past on, you know, Simcoe or you know, you're shopping around Durham region, or you're seeing a movie, or you're going and doing a thing, you're getting a service, that like, these are the people that are helping you do your job better. These are the people that are looking out for their neighbors as well, right?
Yeah, absolutely. Yeah, I can't say thank you more than thank you. You know, it's a great feeling. It's a great feeling.
This might spark some fear that the robots really are coming for our jobs, right? You're like, oh, this is a person could do this, right? But the reality is people are still doing this job. This is a tool in the same sense that, I'm not going to use another example because I'm an idiot and I will butcher the name or something. Scalpel? I don't know.
Yeah, that's
But like, it's not just a matter of using it. It needs to be cleaned. It needs to be serviced. It needs to be, you know, like there's someone who I'm sure manages scheduling. You get this day, you get that day. Can you talk, each of you, about the team that's involved with this? Like, can you talk about the people supporting the robot?
Yeah. So we have a wonderful robotic kind of committee and team that helps us support all of the usage. You know, I'll shout out to our head nurse, Lucy Frankie, who is kind of the head who manages the robot, gives us a lot of updates on, you know, fixes or additions or anything about it. She kind of manages a large nursing team that she has helped train and get trained to know every single little detail about this thing. So our day goes smoothly. So there's a huge nursing staff that is very well educated and informed in using the Da Vinci that helps our day go smoother. So without them, we would be nowhere. So they're a very irreplaceable part of the team. Of course, our other members, our cleaning staff, so the cleaners in the room are cleaners who clean the equipment itself, like certain instruments go through special, a washing machine. I don't know the actual name, but special washing machine.
You toss in a couple of Tide Pods,
yeah,
you're good to go, right?
almost. Yeah. And the donors actually helped fund for us to get that special washing machine as well. We needed a brand new washer to clean and sterilize a lot of our instruments. So that came from donor funding too, which was excellent. Like, we couldn't have one without the other. We needed them both, and the donors stepped up and helped us with that. So that's just a small part of our team. You know, there's an administration side too. Yeah. Maybe Julie can mention.
Yeah, no, I think like it's like a cast of thousands that really brings the robotic program to life. Like, I have to give credit to the amount of hours and effort that Da Vinci put into training us. Elena mentioned about the nursing staff, and it's not just all the incredible work that they do every day on the robot right now, but we work some long hours in those first few cases where you're just going up the learning curve and everybody is new to the process. And like, you know, they really put in that effort. We have surgical assists that stand on the bedside and that are exchanging equipment, and they work with us too. And similarly, like, the process is incredibly efficient now, a year later, but like those first couple months, like, those cases were long and they were hard. And then we've been collecting a lot of data. You heard me talking about a little bit of that. So like, just in terms of the infrastructure from the administrators, in terms of how much they've supported us and helped us collect that data and work through it, they've really made a lot of efforts. So I hope we haven't missed anybody, but the thing I would want to get across is that it's really been a group effort, a team effort. There's nobody that's been involved in this process that didn't give 110% to get this program off the ground. It's been really great.
It sounds like you've just got such a good team, like an enviable team.
Yeah, and it's and we're not even faking it, like, for the camera. Like, it's just real.
Just what it is. It's
everyone
really real.
Is great, and we love working with everyone.
Yeah,
like,
it's been
that's it.
It's been. We feel very fortunate.
And nobody's stealing anybody else's food from the staff room.
Because
you could be a really good colleague, but like, as soon as you're stealing, like, mine, who ate my ham sandwich? What's going on here?
Yeah, I don't think so. No.
Label your food.
Label your food. I think label your food is good policy.
Yes, absolutely. You accomplished 300 surgeries. in your first year with this robot.
Yes, we did.
I'm sure that's almost a surgery a day. That's crazy.
It's a lot of surgeries.
What was the initial projection?
Yeah, like we passed the projections of how
Yeah.
many surgeries we'd be able to do in the year time frame or whatever.
A couple of keeners over here, hey?
Well, but I know that we hit, I believe, our year 3 goal in year 1. So we thought it would take us 3 years to get to that point. But I was not surprised. I trusted my team.
Yeah.
So I trusted my team to do their job.
Were you like an A is not good enough? It should have been an A+. It should have actually been 400.
I was a certain kind of student, yeah.
Yeah, I bet.
So,
You're correcting the teacher's homework. You're like, come on, step it up.
quietly in the background. Like, it is a great number. I'm happy, but I expected us to do that. I expect great things of this organization. Lakeridge Health is a great organization.
So 300, you passed expectations, but you're like, we assumed we were going to do that.
I assumed that we would be able to achieve our goals.
Yeah, and I do think the Da Vinci heads, did say that our program had one of the most successful launches with just, the quality of surgeries that were able to be done and the quantity and being able to have enough surgeons kind of rotate through using the Da Vinci in a very capable way. So I think they've made the model of how we introduce the robot to our surgical division a model that they're going to be trying to reproduce with other hospitals that are going to be newly getting the robot.
And they were so happy they're going to give you another new free robot, right?
I was,
the haptic one.
I wouldn't say no.
Yeah. You're like,
no.
1, I want 6 more. I want 7 more. Come on, what are we doing here?
Yeah.
Thanks to Dr. Elena Igwe and Dr. Julianne Francis for joining us on Brace for Impact presented by Lakeridge Health Foundation. We want to give you a sneak peek behind the scenes look on how donor support makes all of this happen. We want to inspire you. We want to motivate you to make a difference in your own way, because it's people like you that are making a difference in this community. My name is Kolter. Join me by giving or getting involved at braceforimpactpod.ca.